Hello, myself Dr. Akash Sampat. I am the general physician from Nakshatra Hospital, Morbi. Today we have a topic regarding a case study of a 57-year-old man with type 2 diabetes, hypertension, and having microalbuminuria. A 57-year-old type 2 diabetes male for 4 years visited to my clinic from last 2 months, and during the routine checkup complained of the generalized weakness. Patient having the diabetes since 4 years on tablet metformin 1 gram BD, glimepiride 4 milligram OD, losartan 50 milligram OD, atorvastatin 40 milligram OD, tablet amlodipine 5 milligram OD, and chlorthalidone, and metoprolol, and aspirin. And on laboratory parameters, there was HbA1c 8.2 milligram per percentage, and the cholesterol was 75 milligram per deciliter, LDL, and creatinine was 1.1. And from physical examination, the BP is 120 by 80, heart rate is within normal limit. Now we have here the case study of the ACL2 inhibitor group combination with diphenyldiazide group. Now there is to having the optimized glycemic control with cardio-renal protection are the primary treatment consideration, and HbA1c goal for the many non-pregnant adult of less than 7% is appropriate. On the basis of the provider judgment and patient preference, there is an achievement of the lower HbA1c level with less than 6.5% with the combination of the drug. Now there is a renal disorder which are common in type 2 diabetes, with approximately 50% of patients developing some degree of renal impairment, and there is an increasing prevalence of both conditions over the time. The risk of renal disorder 20% in type 2 diabetes. Now, over the 50% of the people with renal impairment on empagliflozin, there is a good recovery and there is a less chances of cardiovascular disease. Now, the empagliflozin reticulate outcome was randomized double-blind trial, placebo-controlled trial involving the 7,000 people with type 2 diabetes, almost all with the established CVD. The mean eGFR at the baseline was 74.1 ml per minute for 1.73 meters square, and median USCR was 18 milligram. Now, the prescribed renal outcome in this study included incident on worsening the nephropathy defined as progression to the macroalbuminuria, doubling of the serum creatinine associated with eGFR. Now, a main driver for the reduction in nephropathy with empagliflozin was a slower progression to macroalbuminuria. Compared with placebo, empagliflozin was associated with significant improvement in post compared the point of incident of worsening the nephropathy, cardiovascular death. There is a decrease in the macroalbuminuria and decrease in the dialysis with the patient on empagliflozin. Now, the inhibition of SCL2 leads to tuberoglobular feedback via enhanced natriuresis and delivery of the sodium to macula densa, thereby decreasing the diabetic glomerular hyperfiltration due to the hyperglycemia. This is hypothesized to reduce the resulting chronic kidney damage. Ketone body are the more energy efficient fuel in the renal tubular cell than glucose, and as a result, the renal oxygen consumption is reduced in the presence of the mild ketosis. Hence, it has been suggested that the use of ketone body as energy substrate in patients receiving SGL2 inhibitor may contribute to the renoprotective effect of this agent with similar mechanism as in the myocardium. Now, the diphenyl peptidase inhibitor reportedly ameliorate the renal function and pathology in DKD. Linagliptin decreases the podocyte apoptosis, one feature of the DKD pathology, by enhancing the insulin signaling. The Carmelina study, which is a linagliptin CV outcome study, confirmed that the linagliptin reduced the progression of albinuria by 14%, reduced the risk of progression of albinuria. Moreover, the linagliptin demonstrated the CV safety, including in patients with the advanced CKD. Linagliptin slowed the progression of albinuria without affecting eGFR or other kidney outcome. There is a strong rationale for combining a DPP and CV protective class of SGL2 in patients with type 2 diabetes because two drugs exert the different and complementary glucose lowering effect. Furthermore, the increase of the glucagon level induced by SGL2 may be blunted by the co-administration of DPP. Clinical evidence shows that the SGL2 combination is an effective option for management of type 2 diabetes, providing HbA1c reduction of 1.1 to 1.5% and weight reduction of approximately 2 kg when added to metformin, which is its primary place in therapy. In the phase 3 random trial investigating the efficacy and safety of empagliflozin linagliptin, there is a better tolerability was observed in the subject who are emphysema than those on the alone empagliflozin in terms of the serious adverse reactions like hypoglycemia, genital infection, etc. Implies that the emphalina add-on to the metformin constitute the equal or even better tolerability than the monotherapy with the additive glycemic efficacy in uncontrolled patients. This unique combination lends itself readily to the early treatment intensification because of the good glycemic control and tolerability, possible weight loss, CV protection, and minimal treatment burden, offers the renal protection patient with type 2 diabetes at high risk. So that is the conclusion, that using the empagliflozin and linagliptin combination that will lead to the decrease in the cardiovascular death and offers the better renal protection in patients with type 2 diabetes. Thank you.